Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. In this video, we will continue speaking about sarcoidosis, and in that video, I will speak about extrathoracic manifestations of sarcoidosis. And in that context, we should refer to variations of the extrathoracic manifestations in sarcoidosis according to ethnic origin and sex of the patient. Systemic symptoms of sarcoidosis are common, such as fever, sweats, loss of appetite, weight loss, fatigue, malaise, chest pain, dyspnea, and cough. Polyarthralgia often affects the knees, ankles, wrists, and elbows, and can be improved by non-steroidal anti-inflammatory drugs. Hypercalcemia. Granulomata convert vitamin D3 to active 1,25 dihydroxy cholecalciferol, and this causes enhanced calcium absorption from intestine. Sunlight also increases levels of vitamin D and calcium. The high calcium may cause systemic effects, and it's often associated with renal damage and hypercalciuria. Hypercalcemia is common in Caucasian and in men. Treatment: if mildly raised, limited dietary calcium intake, avoid sun exposure, and drink plenty of fluids. Otherwise, steroids often low dose once calcium level controlled should be within 2 weeks. If not, investigate for other cause for hypercalcemia. Decrease dose when calcium level satisfactory. And some patients may only need steroids during summer months, and hydroxychloroquine can also be used. Skin manifestations in sarcoidosis. 25% of patients have skin involvement, and more common in women. And skin manifestations of sarcoidosis include the following: erythema nodosum, raised papules, nodules, or plaques, usually on chins, and also tender, indurated, or bruised appearance, firm, and often have shiny appearance. Nodular change involving different tattoo colors recognized and is characteristic of sarcoidosis. Sarcoid tissue may arise in old scars or cause scar hypertrophy. Lupus perineum is a bluish thing or bluish thing that occurs on nose, cheeks, and ears. It's associated with chronic disease. Diagnosis: usually easily biopsied. The treatment: initially with topical preparations, and lupus perineum should be treated with systemic steroids. Hydroxychloroquine or methotrexate may be necessary. Role of long-term tetracyclines or cutaneous sarcoidosis are under investigation. The eye manifestation. Eye manifestations is common and occurring in 25% plus of cases, especially women and African African Caribbeans. Uveitis, either acute or chronic, episcleritis, scleritis, glaucoma, conjunctivitis, and renal involvement or retinal involvement can occur. It may be asymptomatic. It may be asymptomatic or cause painful red eye with photophobia, lacrimation, and blurred vision. Pupil irregular or constricted, untreated, if untreated, can cause visual impairment. Diagnosis of eye manifestations can be confirmed by ophthalmologist who with slit lamp examination of any ocular symptom, and some recommend that all newly diagnosed patients with sarcoidosis have a slit lamp examination. Mild asymptomatic eye involvement is common and may need conjunctival biopsy if no evidence of sarcoid elsewhere. Treatment of sarcoidosis include local steroids. Treatment of eye manifestations of sarcoidosis, local steroids are commonly used if there is no other indication for systemic steroids. However, if it does not respond, systemic steroids should be used. Now we will speak about the heart involvement in sarcoidosis. Cardiac sarcoidosis occur in 5% of patients with pulmonary disease, and post-mortem studies show cardiac sarcoidosis is present in 25%, so is often undiagnosed. Patients may present with chest pain or more commonly are found to have conduction defects on the ECG. This may be benign and asymptomatic, but first degree heart block may be more significant, or other significant arrhythmia can occur, and sudden death from cardiac involvement can occur. Myocardial granulomata can occur in any part of heart. Commonly, they occur in the interventricular septum where they can affect nodal and conducting tissue. The left ventricle wall can be affected with fibrosis, causing reduced compliance and contractile difficulties, leading to cardiac failure. Aneurysms can form and pericarditis can occur. Valvular dysfunction due to infiltration of the papillary muscle is rare, and the clinical course can be uncertain. In suspected heart affection of sarcoidosis, we should do echo, which may show signs of cardiomyopathy, usually restrictive type, and MRI or technetium scan and gallium scan show non-segmental fixed defects. Biopsy is diagnostic but can be difficult as sarcoidosis is patchy and is not recommended in general. ECG and 24-hour tape may be helpful in identifying potentially fatal arrhythmias and conduction defects. Treatment of cardiac sarcoidosis must be treated. Cardiac sarcoidosis must be treated with systemic steroids in form of 20 to 40 mg prednisolone per day, which improve symptoms and ECG and echo fissures. And this should be slowly reduced, but intractable arrhythmias may be or may need continued high dosage, may need other immunosuppressants, and investigate with 24-hour tape and electrophysiological studies if uncertain. Amiodarone and pacemaker and implantable defibrillator or heart transplant may be necessary. In clinic, we should perform a screening ECG on all patients with sarcoidosis perhaps every 6 months. Other extrathoracic manifestations of sarcoidosis include the kidney affection. A degree of renal involvement is found in 35% of patients with sarcoidosis, rarely can present with renal failure, especially following onset of hypercalcemia. Diagnosis done or can be done by renal biopsy with granulomata found in interstitium, but this is rarely needed in this context. Treatment: steroids plus minus hydroxychloroquine for hypercalcemia. CNS affection in sarcoidosis. CNS involved in 4 to 80% of patients. Sarcoidosis can affect any part of peripheral or central nervous system and can present as a peripheral nerve or cranial nerve lesion, and most common is lower motor neuron facial nerve palsy, with optic nerve involvement being next most common, and the mononeuritis multiplex recognized may be less specific with psychiatric features. Hypothalamic granulomata may cause diabetes insipidus, appetite disturbance, or hypersomnolence. Diagnosed difficult, but may be made easier of if there is another sign of systemic sarcoidosis, such as bilateral hilar lymphadenopathy. Lumbar puncture can be used and shows a raised CSF angiotensin converting enzyme ACE, and an increased lymphocyte count can be used in diagnosis. Confirm with biopsy. If possible, cerebral or meningeal tissue if no pulmonary involvement. Treatment must be treated with steroids that often resistant to treatment, may need to try further immunosuppressants such as TNF alpha inhibitors, tissue necrosis factor inhibitor, tissue necrosis factor alpha inhibitor. Now we'll go to musculoskeletal affection. Arthralgia is common in sarcoidosis, but arthritis is unusual. Arthralgia commonly affects the ankles and feet in men, but also hands, wrists, and elbows. A subacute proximal myopathy can occur as well as bone cysts, especially if terminal phalanges. The latter show little response to systemic steroids. Diagnosis: granuloma seen on muscle biopsy. Treatment: non-steroidal anti-inflammatory drugs and steroids may be necessary. Gastrointestinal affection: 60% of liver biopsies on patients with sarcoidosis show granuloma, frequently asymptomatic. Hepatomegaly is unusual but can get portal fibrosis and cirrhosis, and liver function tests suggestive if larger than 3 folds of normal, especially ALB and gamma GT. Diagnosis, biopsy. Treatment, steroids may be used to reduce the size of liver and improves liver function tests. Hematological affection in sarcoidosis, splenomegaly can occur and may be massive, causing abdominal discomfort. A massive spleen may require splenectomy to avoid rupture. Associated anemia, neutropenia, and thrombocytopenia, lymphopenia often seen. ENT, nasal or laryngeal granuloma occur in sarcoidosis and sinus invasion, parotid and other salivary gland enlargement or dry mouth. Finally, it's rare to find breast disease, ovarian or testicular masses in sarcoidosis. That's all, and thank you. I hope you get benefit from this video.